All right. So we are going to start the taping. Thank you, Dr. Rankin, for being here. We're really excited to hear your discussion. We have a little bit of feedback, but nothing crazy. So
But
I think, yeah, I think it'll be all right. Let me get into here. All right. You want to take it from here, Dr. Rankin?
Sure. Well, thank you, Sam, for the opportunity to present the group. I hope to clarify some and not complicate people's understanding of this aspect of stroke recovery. Just kind of as a background, this is I consider a graduate level course, and but there won't be any test at the end, and there's going to be no credits awarded. Um, I hope to bring some real complex ideas down to a basic understanding too. And Sam, you can probably move to the first slide if you would.
Sure.
Very good. Okay, so today what I plan to do is touch on five facets of recovery, and I've arranged them in such a way that they kind of build on each other. As I know here, functional brain neuroanatomy, I think that's the foundation of basically understanding of what we are as human beings, types of strokes, course of neurobehavioral recovery, with a discussion and notable syndromes associated with that, treatments, as well as prevention. And for this, yep, that's
Sorry. I'm jumping ahead.
jumped ahead. That's great. All right. First,
Sorry.
oh, no problem. First, we're going to do a quick overview of the different parts of the brain. As we know, there's two halves. There's a right half, there's a left half. Each half has its own, it says four parts, a temporal lobe, an occipital lobe, a parietal lobe, and a frontal lobe. And then there's that little walnut in the back, which is the cerebellum, and a middle part, which is basically the midbrain, limbic system, and spinal cord, and medulla, which of course is into the spinal cord. As I want to point out here is neuroanatomy is basically the foundation of our understanding on which we build this knowledge base of neuropsychology and neuroscience. Couple of different interesting points of this is everything we know about human thought and theory of mind we know from two different pathologies, specifically stroke and seizures. And it's important to understand that that is indeed the case. Again, it's also important to understand that we as neuroscientists know very little about how a normal brain works. We study abnormal brains and infer what normal is supposed to look like. Case in point, back to the first point that I just said, everything we know about human thought and theory of mind, we know from two different pathologies, stroke and seizures. And we could probably go to the next slide here. Okay, so as I tell patients as I go through my day is that we are basically a neurochemical cell that happens to be self-aware. You change the chemistry of the brain or the structure, and you change the self. This is going to get a little philosophical, philosophy of thought, philosophy of neuroscience, but bear with me here. It's kind of interesting. So two things can change that. Environment works on this neurochemical stack that we are, either positively or negatively through experience, such as how we grow up, psychotherapy if we're inclined for that, relationships with other individuals, as well as nutrition and various substances. And specifically with regard to substances, drugs, either pharmaceutical or recreational, alter that neurochemistry in a variety of different ways. As I say, another thing I say a lot is all medications are poisons with beneficial side effects. We use those meds to change our brains, which then changes our mind and behavior. By the way, if anyone has any questions or whatnot, please just chime in rather than raise your hand, because I certainly can't see if you're raising your hand. And this gets us to these functional neuroanatomy made ridiculously simple points here. Number one, the brain is the organ of thought. We talked the brain is functionally divided, different parts do different things. Majority of right-handed people are left hemisphere dominant for language, and most left-handed people are left hemisphere for dominant for language as well. That brings me to my next point here. As humans, we're essentially all wired up the same way. And we're language-based creatures, which means that basically, as we developed as organisms throughout the course of time, there are various ways that we developed. And one way humans developed was that we were, again, language-based creatures. We use sounds and symbols to communicate ideas to other organisms. And that has developed from grunts and howls to written words, for pictures, to written words, to paragraphs, to now what we have here with the entire, the internet and like even what we're doing here, me conveying all these complicated ideas to an audience. And for the most part, for that too, as I say here, the majority of right-handed people are left hemisphere dominant for language. Language, one of the asymmetries in the brain is that the left hemisphere is dominant for language. That means that their language skills are located for the majority of people in that side of the brain. The reason we're right-handed is because this is the quickest way out for that information. That's why we're right-handed. You can also look at some asymmetries too. If you look at your thumb beds, and if everyone's right-handed, it makes it easier. Typically the thumb bed on the right thumb is wider than the left, and that has to do with another one of those asymmetries. In the brain, the asymmetry is on the temporal lobes, and showing that where these language skills are residing.
Very interesting.
What's that?
That's really interesting.
Yeah. I'm full of these useless kind of neurocognitive facts, and so I'll try to share as many of them as I can think of as I go along today. Understanding what makes us us has a long history as well, dating all the way back to the Greeks, with this dualist notion that there's a brain, and separate to the brain is a mind. And that's how it's kind of went along for a while, is that there were two different things. There was mind and there was brain. As we went along, our evolution of thinking about thinking led us to our current understanding that mind is actually an offshoot of brain, that mind doesn't necessarily exist without brain, and the two are inextricably linked together. Mind and brain are one and the same. You alter the brain, you alter the mind. You can change the mind through education and whatnot, which can oftentimes make changes in brain plasticity. That's to a point. And then we hark back to what I first talked about at the beginning. What we know about brain function, we know from damaged brains. We know very little about how normal brains work. I'm going to talk a little bit more here in a moment about that. But I'm going to recap everything that I've talked about thus far, which is that we infer normal from abnormal, brain and mind inseparable. We're all essentially wired up the same way. And if a part is injured, it manifests itself in specific ways, either physically in terms of sensory and motor deficits, emotional or behavioral deficits, depending on where that is, as well as cognitive difficulties that may manifest in either attention, memory, language, complex problem solving, reasoning, or being able to keep us from doing things that we would otherwise not do. And I think now would be a good time to change the next slide.
Okay.
Okay. So we're going to look at deficits associated with specific regions of the brain. Okay, I'm going to talk generally about these areas first, as we talked about before, the four lobes of the brain. The temporal lobe, we got one on the right, one on the left. Those have a lot to do with memory. There's a specific structure within the temporal lobe called the hippocampus, which allows us to consolidate short-term memory into long-term memory. So for instance, if I said, I'm going to give you 3 words I want you to remember, So I'm going to say apple, book, and coat. And I would expect you, you're going to repeat that back. And I'm going to say, I want you to remember that. That's the consolidation part where I'm going to ask you in, say, 5 minutes what those three words are. And just to help you out, and this is another component of executive function. So the answers is A, B, and C, apple, book, and coat. That's another helpful way to code that information. The occipital lobe, which is in the back, is where visual processing takes place. And I say visual processing as opposed to visual um, um, sensing. The eyeballs sense information and bring that back to the occipital lobe where it's processed and understood. And then we're going to go, Sam, if we go up our back one, and yeah, then we're going to, nope. And one more.
Okay.
Yeah, okay, parietal lobe. Parietal lobe is where sensory information comes in, either with so your ability to touch, and that information gets processed in the parietal lobes. Right hand sensation gets processed in the left parietal lobe. A left hand sensation gets processed in the right parietal lobe. And there's also some very interesting parts of the parietal lobe too, which allows us to integrate this information, be it hearing, be it vision, be it sensation, comes together and is processed. So for instance, if I said, I want you to show me how to use a key, okay, first you have to think of three different things. What is a key? What's it look like? You have to have, what does it feel like? And how would it operate on the world? Those three things go together in that particular area. And then finally, the frontal lobe, which has to do with basically motor output, as well as neurobehavioral aspects of functioning. Now we'll go back one slide, because now I'm going to go left temporal, right temporal. So left temporal lobe, in the majority of folks who are right-handed, because we're all wired up the same, has to do with deficits there have to do with impairment of verbal memory. A right temporal lobe has deficits associated with visual memory. There's this interesting thing, you'll see these kind of odd Greek words that are peppered through here as well. Prosopagnosia. That is a disorder where a person is unable to recognize familiar faces. It's a memory disorder that's associated with, and so the family looks like they've been replaced by other people. And they don't know these people, although they've lived with them their entire life. It's a fascinating sort of thing to see. Some of the other deficits you might see with left temporal lobe injuries are anomia, which basically is inability to name. And you can have similar things in the right temporal lobe, anomia for facial expressions and object recognition. Very similar sorts of thing. The occipital lobes, we're going to look at in terms of how the visual system is put together a little bit farther down the road. Looks at something called hemianopsia, which is basically an inability to see visual information coming from the contralateral side. That basically means you got an injury in the right side of the brain. You're not seeing things on the left side of your hemispace, your world. A lot of folks and patients sometimes will have a difficult time voicing what they're seeing. They say, I can't see out of my right eye. What they really mean is they can't see out of the right side of their world or the left side of their world, depending on what the injury is. And of course, there's ways to test that, obviously, and I think most of us are pretty skilled at doing that at this point. The other is something called Berlin syndrome, which has a very interesting sort of thing that you might see with something called supranuclear palsy. You have, optic apraxia and optic ataxia. And the other interesting things too is something called puralexia, where a person has an inability, who has read in the past, an inability to now read. you can sometimes get something called alexia without agraphia, which I usually find in patients, usually happens when I'm evaluating patients at about 4 o'clock on Friday afternoon, because I'm excited as can be because I found someone with this really bizarre neurological syndrome and there's no one to share it with. It's happened to me time and time again. And where the person, you can have them write a sentence, take it away, and then give it back to them and say, what does that say? And they say, I don't know what that says.
Oh my goodness.
Pretty fascinating stuff.
Really?
Yeah.
Really exciting.
Now, if we go to the next one.
Here?
Yeah. Oh, wait a minute. Back
Ooh.
to that one, parietal lobes. Okay.
Okay.
Talk about left parietal, right parietal. Talk about something called sensory impairments, where a person is going to have difficulty sensing things on the opposite side. If they have an injury to left parietal lobe, having problems sensing things on the right, vice versa for right parietal lobe injuries. Something called amusia, which is difficulties understanding music. This thing called agnosia, which is an inability to know. Tactile agnosia is an interesting phenomenon too to happen with left parietal injuries, where you can put objects in a person's hand that they can't see and ask them to tell you what that is. And they're like, like a key or, a coin or something like that, and say, I don't know what that is. I can tell it's flat, I can tell it's round, but I just don't know what that is. The specific types of aphasia that go with left parietal are left hemisphere injuries in particular, but left parietal we're going to talk about in a little bit. Trimodal neglect is an attention phenomena that is associated with parietal lobe injury, right parietal lobe injuries, where a person can necessarily perceive things in their world, but they tend not to pay attention to things on that side of the world. And this can lead to some pretty significant problems, particularly if a person has what's called left visual neglect, where they can see, but if there's competing stimuli, person is not paying attention to stuff on the left. Things with left visual neglect often goes with agnosia, which means they don't think that anything's wrong with them either. So you got these two problems of not paying attention to left and not thinking anything's wrong with them. And these folks usually think they're perfectly okay to go drive.
Oh,
And it leads to big problems, especially because you're trying to convince someone who's unconvincible that they can't do something that they feel completely okay to do. So then finally, we got the frontal lobes. Frontal lobes are fun because injuries to the frontal lobe, particularly because I do a lot of work with traumatic brain injury. And folks with traumatic brain injury tend to have injuries to the frontal lobes. And that really can be a lot of fun because folks are typically agitated and they're disinhibited and they say things they shouldn't say and they just act goofy. Of course, we got the motor components of that. You got, injury to the left frontal lobe. You're going to have problems with the right side of being able to move, particularly depending on where on the frontal lobe that it's injured, either hand or face or arm. You might have something with left hemisphere or left frontal lobe injury, something called Broca's aphasia, which is an expressive language disorder. Amnesia with confabulation, which basically means that not only do they can't remember, but they just fill in the gaps with wild things, and that's fun. Other side for the right frontal lobe, again, we talked about expressive prosodias, which is basically it's kind of like a language disorder, but for the intonation of speech. So a person will just talk very monotone and they don't have any inflection. Sometimes people think they're depressed, but they're not depressed. They just don't have any ability to impart that emotional inflection into their language. And of course, we talk about defective social conduct. They might do things that are totally out of character for themselves. So now I think great.
okay.
Okay. Where am I here? Uh, did, were there's ones about types of strokes, or is that course?
No, this is the next one.
Well, we'll leave that there, and I'm just going to run through this next leap that we've had.
Okay.
That's good. So next leap, we talked about brain, we talked about brain lobes, we talked about all that. Now, unique to stroke is the cerebrovascular overlay. And this was one of the hardest things for me as I was, going through neuropsychology school, is learning that how that vascular is superimposed on that anatomy, and then injuries in specific area, those arteries, are the things that then cause underlying pathologies, which lead to the impairments that one sees neuropsychologically, neurobehaviorally, or physically. And folks may or may not know, the brain's fed by arteries that come straight off the aorta. 20% of oxygenated blood goes right to the heart. There's two carotid arteries. There's two vertebrals that fuse to become the basilar artery. They link right at the base of the brain to form a unique structure of ringed arteries that from there branch off to feed the brain. There are types of strokes associated. There's essentially three types of strokes. One I'm going to throw in. There's thrombotic, which is where you have basically a tamponating off of blood flow within the vessel. You have embolic, which of course one type is a TIA, or a RIND, reversible ischemic neurological defect, and which is basically a clot that clogs up the artery at some point and prevents blood flow. And then a third is hemorrhagic, which is what we see with AVMs, or also you also see with aneurysms of different types. So here's a pearl for this. It's the type of stroke that impedes brain flow, that causes the pathology specific to the brain, that causes the physical, cognitive, emotional deficits that we may or may not see. I'll say that again because that's a lot of information. It's the type of stroke that impedes the brain flow, that causes pathology to specific parts of the brain, that then causes the physical, cognitive, and emotional deficits we may or may not see. Hope that's clear enough.
Mm-hmm.
If it isn't, it's okay to ask. Okay, now we've touched on neuroanatomy. We've specific cerebrovascular pathologies and why one stroke looks one way, why one stroke looks different. So the course of neurobehavioral recovery, the goal is to maximize functional recovery, be it physically, neuropsychologically. The end goal is, of course, to return the person to the greatest level of independence that is possible, regardless of which path of recovery best serves the patient's needs. Physical recovery, the typical course is proximal to distal, which means that you get improvements close to the body before you get improvements farther away from the body. Majority of recovery can be within 6 or 12 months. Neuropsychological recovery, typically maximum recovery plateaus between 6 and 12 months. And I've known, this is not only research, but me having evaluated people over 30 years, evaluating certain points of their recovery process, and sometimes doing serial evaluations of folks and seeing where that kind of plateaus out. The typical trajectory of recovery is maximal at the end of 6 months, and the recovery curve flattens out as it extends out 18 months to 2 years. Okay, next one. Okay, I want to discuss associated conditions that are either part of the stroke recovery or a consequence of the stroke itself. First, what is obviously depression and anxiety. As we know, nearly 30% of stroke patients develop depression, either early or late stages. And it's entirely treatable with combination of medications and counseling. Now, there's a what we call a dissociation between left and right hemisphere injuries and manifestation of depression and anxiety. You see more depression in patients with left hemisphere injuries. You see less with right hemisphere injuries, unless the depression, because remember we talked about right hemisphere strokes, that those folks typically don't think anything's wrong with them. So a lot of times the depression in a person with a right hemisphere stroke is not because they feel depressed, but because you're not letting them do something that they think they're fully capable of doing, and they feel stymied.
Wow.
And again, these conditions are treatable with a combination of medication and counseling. Next one up. All right, these are fun disorders. This is what this means is it's a it's not just a psychological denial of the condition. You might see family members saying to you as provider or whatnot, well, they just, it's so bad they just don't want to realize that this has happened to them. And it's like, no, it's more than that. And they don't think that anything's wrong with them. As I try to say to folks at times to try to explain this to them is, imagine if I said to you sitting there, hey, don't mean to alarm you, but you have a large spider on your shoulder. Well, of course you're going to look and you're going to say, there's no spider on my shoulder. And I'm saying, yeah, there is. And then so at the second or third time of me insisting that, you as the person are probably going to say, you're crazy, which is kind of the same dynamic that sets up with folks with agnosia. They don't have an awareness that anything's wrong with them. So, and it's related to physiological damage to the brain structures. And again, they think that there is nothing wrong with it. And it comes, and it can be manifested kind of in several different ways here. One is you will sometimes, and this has actually happened to me at a rehab center I worked at before, is that the patient had a stroke, a right hemisphere stroke, and they were found out laying on the floor in the hospital room. And of course, falls are horrible. And so, it's like they got the person and they put him back in the bed and they're like, did you forget that you can't walk or something like that? And they said, no, someone played this awful trick on me. And they're like, well, what is it? It's like, well, someone put this leg in bed with me and I just wanted to throw it out of the bed. And of course it was attached to them, but they weren't have the awareness that it was attached and out they went with it. This is a neurologically based awareness disorder, and it affects obviously insight, awareness, and judgment as a person goes through the course of their rehabilitation. And it requires, especially for the rehabilitation personnel who are very keen to this, to know that the right hemisphere folks need a lot more observation. And you'll typically, at a rehab hospital, find the folks with the right hemisphere stroke sitting at the nurse's station, for instance.
Mm-hmm.
Because you never know what they're going to do. All right. So, next one. Okay. We talked about aphasia is a disorder of language. And we can think of it, we can break language down into 4 different categories. We can, in terms of expression, repetition, naming, and comprehension. And there are essentially 8 different types of aphasia based on deficits in any of one of those 4 areas. The big ones are language, an expressive language disorder, an expressive aphasia, which means you have impairments of language speech and not being able to repeat and naming problems, but generally those folks can understand very well. If you look at that relative to a receptive language, receptive aphasia, you have a person that can speak typically fluently, although the speech typically does not necessarily make sense, but they can't understand, they can't repeat, and they can't name. Versus global aphasia, where you have impairments in all 4 of those areas: expression, naming, repetition, and comprehension. or an anomic aphasia, which they can do all those other things fine except name. This is seen mostly on the left side of the brain. It's important also to realize that with an expressive or receptive aphasia, like I mentioned, this is a disorder of language. So not only can they not speak, but they can't write. And people might say, "Oh, well, I can, give them a, they can write with their left hand." No, no, that's not going to work either. Um, Both of those things are affected because, again, it's a language disorder, not a speech disorder. Uh, Similar thing for uh, someone who can't understand language. Providing them stuff written is not going to be helpful either because they just can't read either.
Crazy.
Next is visual field gut. So this is a busy slide, but it's really important in terms of how to understand where how vision is distributed throughout the brain. So we basically got a picture here of left and right eyes, and those little like marks can be considered, let's think of it as strokes in those particular areas. And you will get certain deficits associated with injuries in those particular areas. Let's say like right at A. If you think of this like a wiring diagram for like setting up a HVAC system, that's a good way of thinking about it. So you have, at A, that's going to affect and going to take out your right eye. You won't be able to see anything out of that right eye. But you move back past B, you're going to have, at B, you're going to have problems seeing things on both sides of that, on what we call bitemporal injury. You typically don't see strokes at B, but what you do see there is pituitary tumors that put pressure on there, and that's typically the sort of manifestation of a visual impairment that might show up. The person all of a sudden is not seeing things on both sides of their world. Walk back from the optic chiasm there to C, and you can start seeing different how this pathologies manifests themselves to where you get all the way back to E, where you're not seeing things on, for this case, on the left side of the visual field. Is it making sense to people? Okay.
Yeah, no.
Okay, and again, as I said, the degree of impairment is basically correlated with both the location and the size of the stroke.
Yeah.
A small stroke in a small area, and it will affect it in one way, or vice versa. And it is, and it's absolutely like this too. We ran into a trauma patient that that had, and the person severely injured, but she said, "I can't see anything on the left, quadrant of my world." And it was a little bit of a debate between myself and the trauma surgeon, and I was like, "Well, that's a stroke."
Yeah.
He's like, "No, it's something else." I said, "No, no, that's a stroke," and it was a stroke because
Wow.
it's that wired up. All right, next one up, neglect syndromes. Okay,
Mm.
these are fascinating because again, as we talked about a little bit, these typically happen with right hemisphere injuries, right hemisphere strokes. They, there's some degree of left neglect. Neglect can occur in both sensory, auditorily, and visually. And how it presents is the person, if you present stimuli on both sides of their world, let's say they're looking out forward and there's bicyclists coming out on one side and a bicyclist coming on the left side at the same time. They are not going to pay attention because of an attention syndrome, not a sensory syndrome. They're going to not see the person on the left. And that can run into real world consequences. We talked about it because a person may not necessarily know that they don't think anything's wrong with them, so that's why they're fine to drive. And I'll go into another story about this in a minute too. Um, and they can be significantly injured, or they can significantly injure someone. I back probably 25 years ago, we had this unique physiatrist at this other place I worked at, and we then obviously eye to eye. This was one of them. So this individual had a carotid dissection on the right, and he had a massive right hemisphere stroke, and he had significant left neglect. And this physician was certain that he could drive, and I'm like, I am certain he can't drive. Um, and so he went out with him driving, which I was like, well, good for you, man. Um, but so this guy would drive with his wife, and they would be getting on the highway. And remember, it's the left side. So he wouldn't be paying attention to any vehicles coming in on the left side. And his wife would have to tell him, don't merge on traffic yet, which I find frightening.
It's scary.
It's incredibly scary. Um, if this goes away, it typically goes away in 6 months. It's been my experience.
It takes that long?
Yeah, it takes that long. And if it doesn't, it typically is going to stay around. It's just kind of my Rankin rule of thumb. Um, so let me see. What's the next one?
Okay. Well,
Did that get on?
there you go.
Okay.
Treatment.
Treatments. Okay. Treatment for stroke centers around both emergence, such as TPA, our clot remover, and then rehabilitation. You know, we're fortunate enough here at Halifax Health to have a stroke center of excellence, where either TPA, which is what that refers to is recombinant tissue plasminogen activator. It's a treatment of choice, provided as long as it's initiated within 4.5 hours, clearly defined symptom onset. The other is mechanical thrombectomy, which is done by an interventional radiologist. But basically, it's indicated. Basically, they go in and they remove the clot. However, it's indicated in persons with proximal large artery occlusions in the anterior circulation. So, you know, vertebral artery would probably not, I don't think, be part of that unless Sam, you can correct me. Is that true?
Yes. No, that's true.
That's true. And it's usually performed within 6 hours.
We can go up to 24 depending on the collateral circulation.
Okay.
So it makes a big difference in regards to collateral flow,
Okay.
the injury.
And then the next is aggressive physical occupational speech therapy. Once, you know, the emergent critical care aspects of functioning are taken care of. And it's integral in keeping bad things from getting worse while simultaneously strengthening and coordinating muscles and in anticipation of neuronal reinnervation. Basically, as I say, it keeps bad things from getting worse as you wait for a lot of spontaneous recovery to continue to take its role as it goes on. Bad things from getting worse are such as contractures, inability to swallow, neurobehavioral consequences of these functions that all will cause secondary deficits and secondary conditions that will impede recovery.
Spasticity is one of those, right?
Yes, spasticity is one of them. That's, yeah, exactly right. I think the next one, how about the next slide? Let me see what's coming up next. Okay. Yeah, I think the only thing I think I want to throw in too is another aspect of recovery. Yeah, this is it, is developing compensatory strategies, figuring out how to get around a problem, be they physical or cognitive. And I think too, we live in a very cool age, not 2020, but very cool age in terms of utilizing smart technologies to help our lives easier, regardless of any neuropathology. I've had folks with dementias and whatnot, and family members trying to keep people in homes longer because, you know, we're all getting older. I'm getting older. I like my house. I want to stay there till they take me out in a bag, and I want to stay there as long as possible. And so do the patients we care for, and how to help them with that goal in light of the problems that they may have in doing so. And I think as we get older and older, that's going to be easier and easier to do. Another, I think, is going to be cool too with smart technologies and self-driving cars eventually, where an individual can stay at home and get to their doctor's appointment.
That'd be cool.
That'll be really cool. Next slide is probably prevention. The big thing to do is what to do to keep this from happening to an individual. The big one is obviously modification of risk factors. And the big six have always been high blood pressure, diabetes management, high cholesterol, obesity, smoking, and drinking. To manage those risks will be helpful in preventing stroke. Because some things we can't do anything about, particularly those of us who are genetically susceptible to something like this. And then and after the stroke too, is again, continuing modification of risk factors, fall prevention, storing dangerous items. I've been on some home evals with occupational therapy, and they do a wonderful job. And my wife probably hates them because I bring all those sorts of ideas home to prevent from a normal standpoint, get rid of throw rugs, get rid of glass tables. Try not to use ladders at all, especially when you're at my age. And again, keeping bad things from getting worse. And, of course, sometimes that's really hard to do when you got a person who doesn't have anything wrong with them. So key to there is a very devoted and intelligent and thoughtful spouse or family member that can help with that continued rehabilitation as they go farther in the course of their recovery. And then, okay, application in real world settings. And we talked about some of those as well. The physicality, the medical complexities, range of motion, balance, ambulation, helping develop language, especially as a person recovers from these language-based disorders. And the cognition, some of this is going to come back, some of it might come back. It may develop into something that's, was at one time called vascular dementia. We don't use the term dementia anymore. We use major neurocognitive disorder instead of dementia, which basically means there's impairments of complex problem solving and memory, as well as activities, deficits and activities of daily living. So I think the next slide, application of real world settings, the psychosocial changes associated with maybe role changes with an individual from how they were at one point to how they are. A person who may have been a caregiver at one point and has to adjust to psychosocial changes associated with that. Short-term and long-term deficits, the rehabilitation professionals can help identify those things and determine what is appropriate and what is maybe not might go away or for a long time, or if not forever. Grieving the loss, especially the person is aware that there's something wrong with them. Certainly family members or caregivers understanding that, this might be it going forward, and helping them with that loss and that understanding of that loss. It's a big thing. As well as lifestyle changes to diminish those risk factors that we talked about earlier. And I think
That's it.
That's it.
Now, question.
I think I picked up well.
I have a little question, not really a question, but I find it quite fascinating how in-depth the disability can be, not just superficially with the weakness that they're having. You have the psychological components as well, that I think a lot of caregivers don't understand the complexity of a brain injury, whether it be stroke or trauma.
Yes.
And I think just having a better understanding of what that looks like helps them make those decisions for improving how they're going to make those plans for future development and what they're going to do next, right?
Correct. This is a very murky area. I've spent my entire life studying this and understanding this at a very in-depth, and and it's hard at times to convey that to someone until they start understanding that this is not just their arm doesn't, their loved one's arm doesn't work, or they just can't walk, or they just can't speak, but this has affected them as again, because brain and mind are inextricably linked, and you
Right.
change the brain and the mind has changed too, and the person has changed.
I found that just the part of the discussion that you spoke about depression and how the depression doesn't necessarily mean that they're depressed because they have lost function, but it was really invigorating to hear about the patients who are in denial of the disability and that they're just depressed because they're not able to do.
Right. Yeah. And it's not a psychological denial, it's a neuropsychological denial. They don't think anything's wrong with them.
Very intriguing.
Yeah. It's absolutely fascinating. And I found it kind of a, there's some schools of thought that said, okay, I just need to hammer home with them. But again, it's just like me saying there's a spider on your shoulder.
Right.
Well, they discount you entirely.
Yeah.
And so what you have to do is plan B it, which is, talk with the spouse and help them understand that this is just not, they just not wanting to face this, they just don't think anything's wrong with them. And that really puts them in a disadvantage because they're going to do things that they shouldn't do. Like work with power tools or go up, try to get on a ladder or something like that.
Right.
What
about like spousal support? Because you also have like the individual who is in denial that they cannot, like you said, they don't think they have a deficit. And yet then with all the pulling back that their spouse does say, no, you shouldn't, no, you shouldn't. How does that react in a caregiver family type situation? I mean, that's got to put a toll on that family.
It does. And that's sometimes I think pharmacology can help with that too. We use the same sorts of, the same agents that we use for brain injury can be utilized with stroke or any sort of neuro sort of thing. Typically here in Halifax, for brain injury, we use primarily valproic acid and Seroquel to manage folks' agitation or to slow them down in some respects. We don't use benzos, for instance, because that tends to make an older person worse.
Right.
And sometimes just a little bit of pharmacology can help slow this person down a little bit, so you got at least you can grab onto them before they get to that ladder.
Or that moped or
that motorcycle or whatever thing they can go back onto. And it's like, no. And so that sometimes helps. And then, sometimes the family be like, I'm always struck by this too, is, families are like, well, I don't like, I don't want to use any of those drugs, like antidepressants or whatnot, because I might get addicted to them. And I'm like, yeah, but your blood alcohol level was 275 when you came in. They're like, well, what does that have to do with anything? It's like, well, that's a drug.
Yeah.
It's like, that's the same thing. That's just a spacious argument. Your brain is an organ of thought, and it's a neurochemical sac, and because of that, there are chemistries that can help right that because it's not right now.
Fascinating. I mean, the discussion was, I'm so glad to have had you be able to do this piece for us because it really brought light a lot of different concepts and the complicated cases of stroke, or to show that stroke's a little more complicated than what most people initially think of, like it's just a weakness in the arm. It can have greater disabilities for those patients.
And long-standing disabilities.
Right.
That go way past the point where the person gets discharged home from rehabilitation.
Crazy.
Yep.
Well, I wanted to thank you very much. I don't think anybody else is going to pop in to have a conversation. And usually people are very shy.
Well, I thought it was really interesting. Thank you so much. My father-in-law had a frontal lobe stroke and he wanted to drive. So I'm like, oh, no wonder. You must have not known. Okay. Thank you.
Yep.
Awesome.
Well, I sure appreciate have an opportunity to speak like this.